Welcome to the Shockwave Therapy Podcast. My name is James Woolidge, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Welcome to our 8th podcast. Today we are joined by Karsten, Knobloch, one of the world's most well-known lecturers and researchers on the subject of shockwave. He's currently the head of communication for the ISMST. So today we'll be talking a little bit about the conference upcoming in Europe this year. We'll also be discussing safety aspects of shockwave alongside how we differentiate energy levels amongst different devices, focused and radial, and his thoughts on that. And we'll be just discussing Storz's new Magnetolith, an EMTT device, and how he blends that with a shockwave service. He's certainly one of the most entertaining and prolific lecturers I've ever come across. So if anyone has an opportunity to listen to him talk, I suggest you do so. So we're really looking forward to what he has to say today. Thanks, Karsten. Hi, Karsten. Welcome to my podcast this evening.
Welcome.
It's been
Welcome, James.
it's been hard work tracking you down because you're just such a rock star and you're too busy. So if
right.
you
Corona is
yeah.
amazing as well.
So if you could just, for everyone who hasn't heard of you, which would be very rare, can you just give everyone a quick summary about you and your impressive shockwave career so far?
So actually, I'm a German physician. I'm a board-certified surgeon in general surgery, in plastic and hand surgery, in emergency medicine, and in sports medicine. And I was working in a university hospital in Hanover until 2012, for 12 years, and then moved to a private practice in December 2012. And the private practice is focusing on non-operative treatments for tendons, for muscles, and for osteoarthritis, as well as for hand surgery. And as far as shockwave is concerned, I started shockwave myself in 2006 when I was still in the university hospital, and I took a course like everybody else and bought a machine for university purposes and started in plastic and aesthetic surgery with the shockwaves in 2006. That's how I started.
Sure. Okay. And in your particular interest in the ISMST, you're head of communication now, aren't you, as well as a certified instructor? So there's a conference. We may as well talk about that quickly now, because given the coronavirus, you're still expected to have the conference this year. I think it's in Vienna, is it?
Yeah. So actually, the situation in the moment is that we have the World Conference on Shockwaves from the ISMST in Vienna end of June.
Okay.
And actually, yesterday, the authorities in Austria, the medical authorities, have postponed all medical meetings or gatherings of 25 plus people, medical professionals in Austria, until mid-April in the moment.
Okay.
So everything until mid-April is cancelled.
Right.
And we do not know in this very moment whether this will be prolonged and how it will develop. So as of now, we are still doing everything for preparation. Abstract submission is still open until March 21st. So you can still think on submitting things on the ismst.com webpage for consideration. And as of now, we are in close contact nearly every second day. However, as of now, we plan to have it done in June in Vienna.
Okay. And for people that are not quite aware of the ISMST, could you just I don't know, give some idea of what the reason would be for us to attend, and what we would get out of it?
So the ISMST is the International Society for Musculoskeletal Shockwave Therapy. It is founded in 1997, and it is the only and the largest world society on Shockwave. So all national societies, like our German DGS, like the Dutch societies and so on, are under the umbrella of the ISMST. And if you are keen on having up-to-date, cutting-edge information well before publication, actually, before a full paper is, usually there are lectures, and then you will have the chance to get to the annual meeting, and this time it will hopefully be in Vienna. Next year it will be in Prague in Czech, and the year after it will be in Seoul. So if you are from the UK, in terms of travel, Vienna and Prague this year, next year are quite easy to access, and to Seoul you have to fly some 8-9 hours from London Heathrow. So it is a very, very good chance. And you see, it is not that often that we come to Europe with this international conference, because last year we were in Beijing and the year before in Auckland, New Zealand. So, and we will have 9 different sessions covering, for example, shockwaves in sexual medicine, shockwaves in sport orthopedics, shockwaves for physiotherapists only. There is a session on the anniversary of the German Shockwave Society, which now counts 25 years this year. We will have a very nice sport medicine session with the Red Bull physician, who is the chief physician of Red Bull Salzburg, who are playing Champions League, as you might know.
Right.
And so it will be hopefully very nice. And we will have both a certification course for physicians and a certification course for the first time for non-physicians, 8 hours, a full day of shockwave practice in Vienna. So it is worth considering it, I would say.
Okay, all right. And that's all on the .com website that you can join and so forth and get tickets.
Right,
okay.
ISMST.com is the webpage, and you can see everything from the hotel, from the program, from scheduling on that webpage.
Okay, great. Thanks for that. So just a couple of questions that we wanted that I posed to you before, just to think about.
Yeah.
So from a teaching perspective, we get asked lots of questions about what exactly is high energy, medium energy, low energy. Could you just give us your thoughts on that? And I think as well, you have a particular take on whether you've copyrighted it or not, your nano energy perspective.
Yeah.
Can you just give some idea on that?
Yeah, so it's not only an idea, it's by definition, let's say. So over the shockwave now is 40 years, and starting in kidney stone resolution, we had very, very high energy flux densities. And by definition, high energy is higher than 0.25 millijoule per square millimeter. This is high energy. Medium energy is in between 0.1 and 0.25 millijoule, and low energy is by definition lower than 0.1 millijoule. This is definition, this is no thought, so that's how things are.
Sure.
The issue is, this is easy for focused and it's hard for radial. And the issue is that the radial pressure waves are not necessarily easily physically translated in these energy levels, I would say. However, with some assumptions, one can say that 2 bars with a radial machine with a standard steel applicator correspond to 0.1 millijoule. So 2 bar is 0.1 millijoule, 1 bar is 0.05 millijoule, 4 bars would be 0.2 millijoule. So by definition, if you only do radial pressure waves, you can do low energy, lower than 0.1 millijoule, so everything lower than 2 bars is low energy. And if you treat in between 2.1 and 5 bars, it's medium energy. And by definition, you will not reach high energy levels because you would have to have more than 5 bars.
Okay.
And this is not clinically useful,
Right.
Therefore, this is not a thing of ideas or thoughts, so this
Sure.
is only physical dimensions and definitions.
Okay.
There is nothing to discuss about,
Okay.
And then one can arrange everything. And I came up with an idea now an idea last year that there are a number of indications where you might or it might be worth separating the low energy field in two separate parts. So low energy on the one hand and nano energy, which is even lower than low energy on the far left hand. It is by definition 0.01 to 0.05 millijoule or 0.3 bar to 1.0 bar. This is all nano energy, so lower than low. And there are a number of indications. For example, the first spasticity paper in 96 was nanoenergetic. We have a lot of data in nerves on carpal tunnel, on cubital tunnel, who are nanoenergetic. We can treat children with nanoenergetic quite successfully. And so there are some indications where even on skin, where we might succeed with very, very low energy, so nano energy. That's a new idea.
And by skin, do you mean aesthetics and wound healing on the skin?
Yeah, aesthetics, not wound healing. Aesthetics.
Okay, right.
Yeah, facial aesthetics, for example.
Right. Okay. Fine. That's excellent. Thanks, Karsten. So, can you ask another common question we get when we're teaching is about the safety profile of Shockwave, and I think the most important question we get asked is it safe in children, in particular in and around growth plates for things like Osgood-Schlatter's and Sever's disease? So could you just give us your ideas on that, or not ideas, ISMST indeed, and contraindications?
Yeah, so on the ISMST webpage, there are, on the one hand, the indications based on beginner, advanced, and expert indications, and on the other hand, there are contraindications. What is important is that these indications are, changed over time. So with more knowledge, with more studies, with more experience, we, a indication 10 years ago, which might have been an expert indication, might become commonplace because of a lot of good data. So therefore, all the indications and the contraindications have to be seen in the light of the year. So this is actual in 2020. And in 2020, Osgood-Schlatter's disease, what you mentioned, is a advanced indication for shockwave therapy. Based on all we know, we have some studies. There is one radial pressure wave study from Heinz Lohra from Frankfurt, I think 5-6 years ago, who did radial pressure waves on Osgood-Schlatter without any problems. And clinically, I myself did do shock waves, even focused shock waves, but with low to medium energy in Osgood-Schlatter disease since 10 years without any premature closure of the epiphyseal plate, and therefore the fear that the growth plate might be harmed was a theoretical one. However, this has not been seen clinically worldwide yet, so it appears quite safe and quite successful, especially in the Osgood-Schlatter patients, in my view, even focused,
Okay, fine. Okay.
And the same holds true, let's say, if you talk on children, we just performed a huge meta-analysis on all trials in spasticity. And we included more than 40 trials published with more than 1,100 patients. And there were 300 children in, I think, 5-6 trials with spasticity. And by definition, if you have a child with spasticity, it is a severely ill patient because he has some cerebral palsy or stroke or whatever causing the spasticity. And there were no, adverse effects in these children with spasticity. So it appears a quite safe therapy even in children. However, Sure. If we only talk on radial pressure waves, you might have to adjust your energy levels. So I would do very, very low energy, nano, for example. And you might, depending on the location you treat in the children, you might have to adjust your applicators. So you might not work with steel applicators, but there are some soft tip applicators, the Atlas, for example, or other tools which help you to make your radial pressure waves feeling much more comfortable for the patient.
Sure. Okay. Our next question that actually we get asked a lot is that historically Shockwave has always been associated with chronic tendinopathies. That's the big indication. But there seems to be, and I know you believe in this as well, there seems to be also a role for Shockwave in treating more acute injuries, less than 3 months by definition. Could you just talk us through your ideas on using Shockwave in acute injury management?
Yeah, sure. So on the one hand, the indications which I mentioned and why there is the term chronic is that the majority of studies in the last 40 years have included patients with pain, with tendon pain, for example, longer than 3 months. Mm-hmm. And there were some early reports, and I just went through 2-3 books published around 2000 with the early experience on shockwaves, even in tendons. And there was one trial from Richard Thiele, who died 3 or 4 years ago, showing that acute cases were worse, acute meaning less than 3 months of pain in tennis elbow and in Achilles tendinopathy in 2000, 20 years ago, mm-hmm. With different machines. They were worse than those patients who had more than 3 months of pain. So this is historically wise one of the reasons why numerous studies were done mainly for chronic indications.
Right.
And there are not that much, if at all, studies on acute, let's say, Achilles tendinopathy. So there are I'm not aware of any, and we have more than 200 studies on Achilles tendinopathy. There is no single study including patients with, let's say, 1 or 2 weeks of pain in Achilles tendinopathy.
Right.
Yeah. So evidence-based wise, there is a clear difference. So we have no data on acute cases.
Okay.
On the other hand, mechanically wise, one can say, okay, if the tendon has a problem, and if we talk on Achilles tendinopathy and the problem is, let's say, for 1 week, and I see in ultrasound the same pattern in an acute case of 1 week duration, like in another case who has 4 months of duration of pain. So he has some inflammation and so on. And in my personal point of view, I fully believe that in this case, the patient will still be appropriate for shockwave treatment, although we have not that much evidence in that case, mm-hmm. because the tendon were the mechanisms involved in tendon healing in shockwaves with stem cell activation, with maybe influence of neovascularization and so on, might happen even earlier. So I'm personal wise, a full advocate of immediate treatments. However, evidence-based wise, we have to say we do not have that much data supporting the acute use of that modality in patients,
Sure. Okay. All right. Just as an aside, I know that you teach mostly Shockwave, and I know that your clinic is full of some wonderful equipment over there. But Storz have just released a version of a PEMF machine, which is a pulsed electromagnetic field therapy machine. I know you were part of the development of that technology for Storz. They call it the Magnetolith. Could you just give us an idea about what that is and how you think it might fit in a modern practice in supporting your treatments?
Yeah. So in fact, the physical modality, it is using its kind of magnetic field, and there are physical marked differences to all the PEMF machines on the market. Mm-hmm. So pulsed electromagnetic field is not what Magnetolith is.
Right.
So from the machine physical properties, there are marked differences in terms of oscillations of the pulse wave and so on. So, but generally speaking, it is kind of a magnetic field therapy. It is a non-painful therapy. It is working apparently by Magnetotransduction, like Shockwave does it itself. However, not by acoustic waves like Shockwave, but by pulse magnetic fields,
Right.
So the idea behind is that there might be some receptors or some sensitivity in tissues on that pulse magnetic fields. And I myself started working on these machines in 2016, so 4 years ago. And we have some good ideas, mainly in the moment, for bones, for bone healing, and for tendons. So these are the two tissues we are most interested in using the Magnetolith in my practice in combination with the combined focused and radial shockwave. So I do it not as a standalone therapy, but as an additional therapy in various, indications at the moment.
Okay. I mean, because I was looking at some of the research on the other PEMF devices, and it seems to be that quite a lot of the research is based upon arthritis, in particular knee arthritis. I'll be posting actually, I think, one of the bits of research that it tries to explain magnetic field therapy after this. But do you see a role for it in arthritis as well, or mostly just bone fracture healing, or?
No, when I say bone as a tissue,
okay,
there is, osteoarthritis included,
Right. Okay. Fine.
So, but we do not have yet any study, and as you know, to perform from the idea over IRB approval, execution of the trial, and publication, this is 5 to 7 years at best.
Okay.
Just to give the audience an idea of how long it will take to perform one trial. So there is a lot of work and a lot of, time spent for, answering questions. And as of now, we do not have data on the EMTT, the electromagnetic transduction therapy, on osteoarthritis. Personally, I treated over the last 4 years a number, the 3-digit number of patients with various osteoarthritis, and with very, very encouraging results. So there might be a place in the future for that therapy, even in osteoarthritis.
Okay, fine. And I think one of the advantages is that you don't need to remove clothes. It's very non-invasive, isn't it, as well? So that's quite helpful, I think, for a lot of patients.
Right. Yeah. Right. You can, You might do it with trousers on. However, the current version, the magnetic field, works better the closer it is to the tissue.
Okay.
And if you have 5 layers of some anoraks in between, so the field strength in the tissue will be diminished. So
okay.
I would rather, that is not a huge issue. So and if you treat a knee, it should be a naked knee. Yeah, a naked
okay,
knee,
fine.
In my view, so to obtain the best possible result,
Sure.
But it's a pleasant, a non-invasive, in between. It's like Shockwaves with shots, so it's in between 4 or 8 minutes of therapy duration, and it will, at least in my practice, it adds quite significantly my therapeutic range. And over the last week where I have that machine actually in place, I did some 27 treatments in 6 days. So just to give you an idea of how frequent I use that machine.
Okay, all right. So going back to some of the Shockwave education that you do. I tend to ask everyone who's a guest on this. I don't think I asked Thomas last time I had him on, but would you how would you rate certain conditions? If you had ideal patients coming in for treatment with Shockwave, what would be your favorite 2 or 3 conditions that you would treat with it that you think it's particularly excellent at?
You mean indication-wise?
Yes, indication-wise, and possibly, you know, the age of the patient and how long they've had the condition for. Are there certain things that you've come around to treating where you think this is a perfect patient for Shockwave, this is exactly what I think is going to be a good result?
Okay. So the problem is the more you know, the harder it is. And, you know, I'm treating 50% of my patients have Achilles tendinopathy.
Okay.
So I did some more than 15,000 sclerosing injections in my life. You know,
how many? Say that again.
15,000. 15,000 sclerosing injections.
Wow.
So therefore, you know, I'm quite familiar with the Achilles tendon.
Yes.
But the more I know, the less and the more I know about, let's say, contributing factors, overload issues, training errors, footage, geometry, cholesterol, and so on, which might somehow harm or somehow reduce my efficacy of shockwaves. You know?
Yeah.
Therefore, I would put it this way. In painful tendons for more than 3 months, this is a very potent machine. However, shockwave alone will not necessarily help in every tendinopathy. So you will have to have eccentric training, you will have to have loading, and so on.
Sure.
In bone, let's say in bones, stress fractures, for example, I see, and this is supported by a number of studies, significant improvement and a faster return to play if you do shockwaves, in contrast to standard treatment in stress fractures. So there I see a full, let's say, a full effect of focused shockwave, because for the bone you need high energy.
Sure.
So for stress fractures.
Would you include shin splints with that medial tibial stress syndrome?
Right. However, it's not it's in the moment an advanced indication. However, as of yesterday, I had a female runner, and my current treatment is focused shockwave and magnetic field for shin splints. So I do the combination, and beforehand I did only shockwave. However, still shin splint is like a tendinopathy, an issue of load, overload, and recovery. So as long as training errors persist, shockwave alone will not solve the problem.
Sure.
100%. You know.
And it is becoming, unfortunately, a little bit like that when we teach. Is everyone the tendency and the fashion is to get the machine and put it on the saw bit and then hope for the best, which then of course means that results are not great.
You know, it's the same with eccentric training only. So you will make a difference, a significant difference after, let's say, 3 months of eccentric training every day. The proper repetitions, 90 repetitions, you will end up with some 50% less pain. This is what you can expect after 3 months.
Yeah.
You know, not more, not less. So, and it's always very important to have an idea of the efficacy and of the amount of, let's say, improvement of pain. And do not believe binary one pain, yes or no. So you will have an improvement, but maybe you will not fix everything with the machine alone or with eccentrics alone. That's what I fully believe on.
Sure. Okay. And I think that most of the questions there I've answered. Is there anything else that you'd want to say about Shockwave or the Magnetolith or anything else for that matter?
I would just point it this way. I started myself using the machines 15 years ago on tendons and on skin and wounds and so on. And I couldn't expect what Shockwave, let's say, or how Shockwaves helped my life, both in a social, both in a familiar, institutional, and way, and in my personal practice way. So in the end, I'm doing 50% of my reimbursement is Shockwave. So I cannot overrate it enough that for me, Shockwave, let's say, saved saved my life and my.
It certainly saved your knee, didn't it? I think it helped with your knee recovery.
Educationally wise and even spiritual wise, and you will see in the future that coming from tendons and bones where we are, or where we have been, that skin is coming, that nerves are coming, that the brain is coming, that the muscle is coming, that several other indications are coming into daily practice in the next 5-10 years, where someone would not expect 4 or 5 years ago. So the future, in my view, although it's 40 years already, is very bright. It hasn't been brighter than today, in my view, in Shockwaves.
No wonder the ISMST have made you head of communication, Karsten. It's been really good.
I'm paid for them now.
When I saw you in London teach at the end of last year, you had some excellent slides. Is there a potential for you to pop a few slides over to put in our notes afterwards?
Yeah. So
particularly that one that I like, I've never seen before, which is the graph you have where you've split high, medium, low, and nano energy and the indications on it. That's a nice one. That.
Yeah. You will get it, and it's worth for the audience to have a look on it. That's supporting what I said and thinking about it. And in my view, the energy, let's say the energy issue, is a big issue because it helps quite a lot, especially if you are dealing with different customers or therapeutics with different machines, with Radial and Focused, and just to have a common language. And energy-wise, you can really compare different machines much more easier than beforehand.
Yeah, sure. Okay, great. All right. I think, Karsten, that's everything that I wanted to ask you, and I'll chase you again over the next year to try and get you back on. But I know I need to give you at least 3 months' notice because you're so busy. But thank you very much for coming on.
Thank Corona, I'm not traveling anymore. So
that's the reason, isn't it? That's the reason. You're stuck in your clinic.
4 cancellations as of today for conferences. So.
Wow. Okay. All right. Thank you very much, Karsten. I'll bid you farewell.
Thank you.
Cheers.
It's been a pleasure.
See you later.
Bye-bye.
Bye-bye. Ciao.